At this juncture, we will begin discussing Lesson 2 under Cardiovascular Pharmacology. As what I have told you, ang foundation nato in studying Lesson 2, 3, and 4 will be the concepts that was discussed under Lesson 1. So very important yung concepts na naaral nyo under Lesson 1. So please do not forget the concepts kasi yan yung gagamitin nyo as foundation to easily understand the preceding lessons. Kasi yung mga agents na gagamitin, ginagamit for the conditions that will be discussed under lesson 2, 3, and 4, mga antihypertensives din. Okay? So, very important na foundation yung hypertension, antihypertensives. So, at this juncture, we will start discussing all about drugs that can be used for angina pectoris. Basically, when we talk about angina pectoris, that is also known as chest pain. Okay? Or sa Tagalog, yan yung pagkirot sa dibdib. Okay? Chest pain. Yung normal chest pain or normal na pain na nararamdaman ng puso, yan actually ay isang cardiovascular response. So, normal yan. However, kapag intermittent na, persistent, tuloy-tuloy yung chest pain, or let's say, in most cases, tuloy-tuloy siya, and then biglang stop, and then proceed na sad, and then stop, na po sudden na chest pain, may mo-stop na po siya, then meron na namang pagkirot sa dibdib. If that is the case, there is already an underlying problem. So, kailangan yan bigyan ng management. And meron po tayong mga agents, mga drugs, available in the market to relieve the uneasiness felt by patient with chest pain. So, ang gap nga atong established dire, okay, bago yung drugs, bakit nga ba nagkakaroon ng angina pectoris? Okay. So actually, yung angina pectoris or yung chest pain, yan ay isang pathological, resultant pathological condition caused by ischemia or kaya naman infarction sa puso. Again ha, yung angina pectoris, yan ay isang resultant pathological condition ng ischemia or kaya naman infarction, kung saan ang reason bakit nagkaroon ng ischemia infarction dahil yan sa tinatawag na coronary artery disease. So, ang point dito is hindi biglaan yung pagkakaroon ng chest pain or angina pectoris. Meron kibali siyang pinag-ugatan or meron siyang root cause. May major problem behind. So because of ischemia or infarction, merong angina. Bakit may ischemia or infarction? Dahil may coronary artery disease. So bago ulit yung drugs for angina, discuss muna natin itong mga reasons, yung mga conditions na to na nagre-resulta sa chest pain. So, simulan natin yung flow ng discussion, okay, sa coronary artery disease. Then, it will be followed by ischemia, infarction, and huli, discuss natin yung definition ng angina pectoris. Bago yung mga drugs for chest pain, angina pectoris, para mas ma-appreciate nyo yung action ng drug. So, let's start with coronary artery disease. Coronary artery disease or CAD, this is also known as ischemic heart disease, coronary heart disease. So, define natin ang sakit based on the terms used. So, i-breakdown nato siya. Alisin muna natin yung word na disease. Okay? So, i-define sa nato una ang coronary artery. Okay? Ano ba yung importance ng coronary arteries? Basically, ang coronary artery ay isang klase ng blood vessels or ugat that supplies oxygen to cardiac cells. Again, blood vessels that delivers oxygenated blood to cardiac cells or cardiac myocytes. Yan yung coronary arteries. Okay? So, ano yung ibig sabihin ng definition? As we all know, ang puso, di ba, sa discussion natin sa introduction ng hypertension, ang puso normally it pumps and then it dilates. It pumps, it dilates. Yun yung normal na ginagawa ng puso. Bakit siya nag-pump? Bakit siya nag-relax? Bakit nag-relax and pump yung puso? Kasi nagtatrabaho yung cardiac cells. Okay? Nagtatrabaho yung mga cardiac cells. And the heart is made up of cardiac cells, cardiac muscles, cardiac myocytes. And of course, para makapagtrabaho ng maayos ang mga cardiac cells, kailangan meron silang gasolina. Dapat meron silang driving force, di ba? And ang fuel na kailangan ng cardiac cells para they could efficiently work, para efficient yung pag-pump, ang pag-relax ng heart, of course, kailangan nila ng oxygen. So, i-take note niyan ha. Yung oxygen, kailangan na kailangan ng cardiac cells para makapag-efficiently work sila. Now, sino naman yung nagsisilbing gasoline station? Nagsusupply ng oxygen sa cardiac cells. Yan yung coronary arteries. So, yan yung importance ng coronary arteries. It delivers, it supplies oxygenated blood to cardiac cells. Okay? And, kailangan na kailangan ng cardiac cells ang oxygen. Now, ano naman yung ini-imply kapag coronary artery disease? Okay? Diba? Ibig sabihin, disease condition, ang nangyayari ngayon, yung mismong blood vessel, yung gasoline station na nagsusupply ng oxygen sa cardiac cells, merong problema. Diba? Kasi disease, condition na siya. Ano yung problema? Basta coronary artery disease. Ano yung problema sa coronary artery? Barado or nagkakaroon ng obstruction of blood vessel, particularly of coronary artery. That is why, as defined, yung coronary artery disease or CAD, this is a condition wherein there is insufficient blood flow to one or more coronary arteries. For example, in the given figure, the figure shown on the right side, diba itong naka-magnify, ganun siya. Yung naka-magnify, yung kulay red, for instance, ito yung coronary artery. Okay, na minagnify, diba gimagnify siya from a portion of the heart. Kaning naka-box dire sa portion ng heart mo na siya, gimagnify lang niya ang coronary artery. So, ibig sabihin, sa illustration na to, ng buong heart, sa illustration ng heart dito, sa buong heart, yung mga kulay red na nakikita nyo, yung mga kulay red na ugat dyan, mga coronary arteries yan. So, imagine nyo na lang, mga coronary arteries yan lahat. Kasi syempre, ang coronary arteries, kalat yan sa puso. Okay? Now, pag sinabing coronary artery disease, okay, may segment lang, may part lang ng coronary artery sa puso ang barado or obstructed. Okay, take note ha, may segment lang or part lang ng coronary artery sa puso ang barado, basta CAD. Halimbawa nga, dito sa segment na to, yung naka-magnify, ano siya, meron tayong makikitang bara or obstruction. Diba? Kanang color yellow sa sulod, kanang siya. Okay? So, naay obstruction sa coronary arteries. So, pag may obstruction, we expect na yung supply ng oxygen dito sa part na to ng puso, konti lang. Di ba? So, pag konti lang yung oxygen supply sa part na yan, we suppose na lesser yung performance ng cardiac cells. Kasi nga, sabi natin kanina, yung cardiac cells, kailangan nila ng oxygen supply so that they can efficiently work. Okay? So, kung lesser yung oxygen supply, we can conclude na lesser yung performance ng cardiac cells, less efficient. Kasi nga, again, wala masyadong oxygen supply sa segment na to ng puso. So, ang point dito ha, kapag may barado, may obstruction sa coronary artery, hindi po buong puso ang kulang sa oxygen supply. Parte lang ng puso na may affected cardiac cell. Kasi, kung lahat ng kulay red dyan, lahat ng ugat ng coronary arteries obstructed, okay, or affected, patay agad ang patient. So, meron lang region, may part lang ng cardiac cell, coronary artery ang barado. Kamalas na lang wag yun kung tanan coronary arteries barado kapag ang patient may CAD. So, tandaan ha, CAD, may segment lang ng coronary arteries ang barado or obstructed. Now, let's proceed to the different causes of coronary artery disease. Lahat ng mga listed causes na to, they lead to deficiency of oxygenation sa mga cardiac myocytes. Okay, so number 1, we have atherosclerosis. So, na-mention ko last time sa lecture 1 yung atherosclerosis. So, somehow meron na kayong idea. Apparently, when we say atherosclerosis, di ba, merong plaque formation. Plaque that is made up of fats na nagde-deposits sa wall of artery. So, say for instance, drawing na lang na ako. Say for instance, ito yung arterial wall. Okay? And kapag may fat deposits, ayan, example na ay fat deposits sa wall ng artery. May mga plaque formation sa walls ng arteries dito. Kumusta ngayon yung daanan? Kumusta ngayon yung diameter ng coronary arteries? Siyempre, magna-narrow, sisikip. And narrowing of coronary arteries, that results to lesser blood flow. And kung lesser yung blood flow in that area, that leads to lesser oxygen supply. Diba? For that area. And that might cause a problem. Say for instance, itong minagnify from the figure shown, di ba? Pwedeng magresulta to dying muscle due to less oxygen supply. Next is thrombosis. Okay, thrombosis naman, that is caused by blood clot in certain areas of coronary artery. Okay, and then ang embolism din, blood clot din siya as well. So, parehas sila blood clot. Okay, may blood clot, may pamumuong dugo. Ano yung pinagkaiba ng thrombosis tsaka embolism? Okay, ako i-arrow ha. Yung thrombosis, yung blood clot formed stationary. Meaning, yung blood clot, nakadeposit lang siya sa arterial wall. Okay? Nakadeposit lang siya sa arterial wall. And ang tawag sa nabuong blood clot na stationary ay thrombus. So, say for example, ito yung erase na lang na ako ni. Ito yung arterial wall ulit. Ayan. So, arterial wall. Then, kay blood clot, namuong dugo. Tapos, nakadikit lang sa arterial wall. Ibig sabihin, stationary siya. Ang tawag sa blood clot na yan is thrombus. Okay? Now, kapag embolism naman, ang blood clot ay traveling. Kapag embolism, ang blood clot formed is traveling. For example, from this thrombus, from this stationary blood clot, may instances na yung clot na stationary, pwedeng ma-cleaved. Okay? So, mag-erase ko part. Ha? So, merong part, ayan, na ma-cleaved. So, say for example, ito na yung na-cleaved na portion ng thrombus. Okay? Syempre ha, hindi buong clot ang ma-cleaved, ang matangtang from that arterial wall. Meron lang portion ng stationary blood clot, station blood clot or thrombus ang matapyas. Okay? Or yung matatanggal, ma-cleaved. So, say for example, itong clot na to, natanggal, natapyas, that will travel. Okay? That could probably, pwede siyang mag-travel around the body and in some cases, pwede siyang mag-clogged, diba? Or mag-deposit, bumara sa coronary artery. And ang tawag naman sa nag-travel na blood clot is embolus. Embolus. Okay? Yung vasospasm naman, that could also cause coronary artery disease that could lead to deficiency in oxygenation sa mga cardiac myocytes. So, i-recall na to ha. I-recall na to. Ang underlying problem sa coronary artery disease is barado. Okay? Barado yung coronary artery. So, CAD, ang reason, barado yung coronary artery. So, we expect, na yung tatanggap sana ng blood supply, nakukulangan. Okay? Nakukulangan ng oxygen supply yung tatanggap sana ng fuel. Okay? Which is dala-dala ng coronary artery. So, if that is the problem, nakukulangan yung cardiac cell, okay, in that area ng heart, that could result to the following problem. Okay? So, una, there could be ischemia. Okay? There could be ischemia. And worst, there could be infarction. So, ito yung pwedeng magresulta with CAD. Okay? So, when we say ischemia, there is only partial damage. Okay? Partial damage in the affected cardiac myocyte. Ibig sabihin, nagkukulang ng oxygen supply ang cardiac cell. Okay? And due to that decreased oxygenation, ang performance ngayon ng cardiac cells declining. Okay? Yes, somehow, working pa rin naman siya, yung cardiac cells, still viable, capable pa rin siya to do its function. However, yung cardiac performance niya is declining. Okay? Nagde-decline. Kasi nga, yung oxygen supply, kulang. Okay? Bakit nga naman gaganahan, di ba, yung cardiac cell kung not enough yung fuel or oxygen supply. Okay? So, ang worst naman na pwedeng magresulta due to CAD is infarction. Sa infarction, as in totally 100%, 100% absent na ang oxygen supply sa isang area ng puso. Okay? Sa isang area ng cardiac cell. So, pag 100%, ang ugat probably barado. Diba? Kung barado, kahit drop lang ng oxygenated blood, walang papasok sa cardiac cell. That's why yung cell, it will die. It will become necrotic. Again, pag may absence of oxygenation, oxygen supply, that could lead to necrosis or cell death. So, as shown in the figure, we have here zone of infarction. Zone of infarction, tingnan yung kulay. Ano yung kulay ng zone of infarction sa illustration? Diba darker yung shade? Kasi nga, patay na yung cell. 'Di ba? Kasi nga sa infarction, as in absent yung oxygen supply in that area. And remember, ang cardiac cells, kailangan nila ng oxygen. Okay? Para they can efficiently work. Kung wala, useless, patay yung cell kung walang oxygen supply. Then, tingnan naman yung zone of ischemia. Ischemia, ano yung kulay ng shade niya? 'Di ba? Faded lang, pero malapit na ring mamatay yung cell. Pero working pa rin naman siya kasi may pakonti-konti pa ring oxygen supply na nare-receive yung cardiac cell. So again ha, ang point dito, part lang ang affected. Hindi po buong puso ang affected. Okay? With CAD. Pero, kapag hindi naman yan naagapan, posibleng mamatay yung pasyente kapag hindi naagapan. Okay? Kapag hindi siya naagapan. Okay? So, i-recall nato. I-recall nato ang pinaka-root, di ba, CAD. Okay, pinaka-root, ani nila tanan, ischemia, infarction, CAD. Sa CAD, barado ang coronary artery. Barado ang problema. Barado yung coronary artery, kaya kumusta yung oxygen supply being delivered sa cardiac cell? Baba yung oxygen supply. Ano yung pwedeng magresulta kapag may oxygen supply deficiency? Pwedeng kulang yung oxygen supply ang nare-receive ng cardiac cell, meaning yan yung ischemia. Kulang, hindi enough. Okay? Okay. Another, kapag completely wala, zero, yung oxygen supply being delivered sa cardiac cell, okay, ang pwedeng magresulta, infarction. Okay? So, yan yung pwedeng results if may coronary artery disease. Now, ang CAD, ang ischemia at saka infarction, malalaman mo na meron ka nito. Malalaman mo na meron ka nito kung naramdaman mo siya first hand. Okay? And ano yung usual symptoms na nararamdaman ng pasyente pag meron siyang ischemia, infarction, CAD? Ano yung usual na nararamdaman ng pasyente? Paninikip ng dibdib. Okay? Or yan yung tinatawag natin na angina pectoris. Okay? So, hindi po biglaan ang angina pectoris. Okay? Basically, ang angina pectoris, ito yung end result ng pagkakaroon ng CAD, ischemia, infarction. Now, angina pectoris or chest pain, ito yung discomfort na nafe-feel ng pasyente due to myocardial ischemia or infarction. Bakit nagkakaroon ng angina pectoris? Kasi nga, masyadong mababa yung oxygen being accepted by the affected cardiac cell. That's why we can say na ang angina pectoris ay connected siya, okay, sa concept na oxygen supply and oxygen demand mismatch. Okay? So, angina pectoris, tandaan, somehow connected siya sa concept na oxygen supply, oxygen demand, imbalance, or mismatch. So, this will be discussed sa pathophysiology later na slides. Okay, so natin segment na ma-discuss natin ni siya na concept, and this is very important kay ma-apply natin ni siya pag-insert na nato sa mga drugs. So, tandaan ha, angina pectoris, okay, related siya sa concept na oxygen demand, oxygen supply mismatch, angina pectoris. Okay? And as I have mentioned, ang underlying cause ay coronary artery disease. Underlying cause. okay, ng angina pectoris, coronary artery disease, pinaka-root cause, pinaka-major problem behind. Now, marami tayong type ng coronary artery disease. Actually, we have 3 major types ng angina pectoris, but the more focus ng drugs that will be discussed, okay, is on the first 2 types. So, yung mga drugs na madadiscuss, ito yung tinetreat nila na types of angina pectoris. Okay, so first we have chronic stable angina pectoris, and then we have Prince metal angina. So let's discuss CSAP first, yung chronic stable angina pectoris. CSAP, chronic stable angina pectoris, this is also known as effort angina. So i-highlight nyo ha, yung effort angina sa inyong note, CSAP. Yan yung chronic stable angina pectoris or classic angina. So yan yung AKA nila. Ang duration ng chest pain na nafe-feel ng patient usually lasts for 2 to 5 minutes. And merong mga triggers. May mga certain triggers na nagpo-provoke, okay, bakit nararamdaman ng patient ang chest pain during CSAP. Okay, so number 1 is physical exertion, physical involvement, okay, ng tao. So say for example, ikaw na may CSAP type of angina, meron kang chronic stable angina pectoris, tapos tumakbo ka, tumalon, nag-exercise. Kapag nag-exercise ka, you feel that chest pain. Okay? Kaya nga ang tawag effort angina. Kasi kapag nag-e-effort ka, masasaktan ka, kumbaga. So that's the time mafe-feel mo yung chest pain. Okay? So yan ang case ng effort angina. Kung kailan ka nag-effort, okay, kailan ka nag-e-effort, tsaka ka naman ma-hurt. So, parang ganun yung concept ng CSAP or effort angina. Another trigger is emotional stress. Yes, emotional stress. So, kung ikaw ay may CSAP, then emotionally distressed ka, ang tendency you feel the chest pain. Exposure to cold and smoking, these certain exertion of efforts na ginagawa ng tao that could make them feel the chest pain. So, ibig sabihin, yung effort angina, kapag hindi ka naman nag-e-exert ng effort, nagpahinga ka lang, nawawala ang chest pain. Okay? So, ibig sabihin, the effort angina, it is being relieved by resting. Okay? It is relieved by resting. Kasi again, kanus aragani nila ma-feel ang chest pain kapag yung tao may CSAP, kapag nag-e-exert ng effort. Okay, may mga triggers. Okay, bakit na feel nila yung chest pain sa mga tao na may CSAP kapag may exertion. Okay, so kumbaga, kung nag-rest ka naman, okay, mawawala yung chest pain na nafe-feel mo. Or, maraging ani yung concept. Kumbaga, kung pagod ka na mag-effort at sobra ka na nasasaktan, magpahinga ka. Mawawala yung pain. Okay? Which is yung chest pain. So, yan yung concept for effort angina. Okay? For this type of angina, there is no increase in severity, okay, duration, and frequency of chest pain in the last 1 to 2 months. Okay, so that's for CSAP. Okay, effort angina, so effort-related siya, yung chest pain na nafe-feel. Now, another type of angina is yung second one, yung Prince metal angina. Okay, Prince metal angina, this is also known, synonymous siya to variant angina vasospastic. Highlight niyo yung vasospastic angina. Ibig sabihin ng vasospastic, may vasospasm, may constriction ng vessels, okay? or aka niya is angina inversa. Okay? Excuse me. Now, ito naman ay because of transient spasm. Okay? Transient spasm of localized portions of the coronary artery. So, the thing here is out of nowhere, your coronary artery constricts. And because of that constriction ng coronary arteries, you feel the chest pain. Okay? So later, you will find out sa pathophysiology, ma-discuss natin na siya. Why is that so? Okay? So that is for Prince metal angina. Okay? So sa discussion nato diri ato sang differentiate ha ang CSAP versus Prince metal angina. So ayan. So sorry for that. Now, ang problema dito sa Prince metal is that even at rest, okay, ayan, even at rest, you still feel the chest pain. Yan yung problema sa Prince metal angina. So, sobrang magkaiba sila ni CSAP or effort angina. So, kumbaga, yung concept sa Prince metal angina is that wala ka na ngang ginagawa, lumalayo ka na nga, di ba? Nasasaktan ka pa rin. Nafe-feel mo pa rin yung chest pain. So, yan yung concept ng Prince metal angina. So, yan yung difference, big difference nila ni effort angina. Okay? So, again with effort angina, yung chest pain, it is relieved by resting. But with Prince metal angina, even at rest, you still feel the pain. Okay? So, pakatandaan, basta angina, ang problema, di ba, may chest pain, may pagkirot sa dibdib. Okay? Now, at this juncture, discuss naman natin clearly, bakit kaya ang effort angina kanina, effort-related yung pain na nafe-feel ng pasyente? Bakit naman dito sa Prince metal angina, even at rest, may chest pain pa rin? So, i-discuss natin siya clearly. So, dito na tayo, So, dito tayo ngayon sa pathophysiology of angina. Basically, ang problema gyud sa angina pectoris, yung sabi ko nga kanina, 'di ba? Hindi po balanse ang salitang supply tsaka demand. Okay, so mayroong oxygen supply, oxygen demand, imbalance. Okay? So sulat na ako ha. So ayan, pathophysiology. Okay? So sulat sana ako. Ayan. So may oxygen supply, then oxygen demand mismatch. Okay, so hindi balanse. Ayan. Okay, inversely proportional. Specifically, there is mismatch. Okay? So, ayan. Now, since always nako gamiton ang terms nga supply tsaka demand, iklaro lang nato ang terms ha para mas masabtan siya. Okay? Pag mag-mention gani kog supply, pag na-mention yung supply, tandaan This is related to the supplier. Okay, supplier or sa ugat na nagsusupply ng gasolina or oxygen. Sa previous slides na na-discuss, anong ugat yon? Ang supplier ng oxygen. Diba? That is coronary artery. Okay, so tandaan ha, basta supply, oxygen supply, related siya sa coronary arteries. Okay? And then, kapag naman sinabing oxygen demand, kapag demand, ito naman ay related sa padadalhan ng oxygen. Okay? Yung susuplayan ng oxygen, yung nagtatrabaho. And that is yung cardiac cells. And syempre, yung cardiac cells, they made up the heart. 'Di ba? Kaya, in short, kapag demand, ang pinag-usapan, I am referring to the heart. So, take note ha. Kapag supply, I am referring to coronary arteries. Kapag demand, syempre, di ba? Sino naman yung magde-demand sa oxygen supply na need niya? Depende sa workload ng heart. So, that is the heart. Okay, siya yung magde-demand. Pila dapat ang oxygen supply nga akong kinahanglan. So, ano dapat si heart? Siya yung magde-demand. Okay? So, coronary arteries, supply, heart or puso, demand. Ang problema ulit sa angina pectoris, hindi balanse. Diba? Hindi balanse, mismatch. Yung oxygen supply, oxygen demand. Okay? So, pag-uusapan natin per condition. Una, CSAP. Yung chest pain, sabi natin sa CSAP, yung chest pain ay related sa effort na nawawala kapag nagpahinga, di ba, ang tao. Okay? So, explain natin bakit ganun yung characteristics ng CSAP. Okay? In CSAP, sabi, because of effort, ayan, because of effort that the person exerts, he or she feels the pain. Question. Kapag ba nag-exercise ka or emotionally distressed ka, nag-exert ka ng effort, does your heart beats faster? Yes or no? Kapag nag-exert ka ng effort, syempre, your heart beats faster. Question. Kapag nagpa-pump faster ang puso, how will you assess the workload of the heart? Kumusta ngayon ang workload ng puso kapag stressed situations? Okay, kapag nagpa-pump faster ang puso, is it more or less workload? Siyempre, it is more workload. Another question. Kapag ba increase or more workload, ang puso ba ngayon, para maging efficiently working ang puso, does it need more gasoline? Does it need more oxygen? Does it need more oxygen kapag increase yung workload ng puso? Yes or no? Yes. Okay. So, sa CSAP, ganito yung nangyayari. Take note ha, paminaw. Paminaw. Dahil sa pag-e-effort mo, ang puso mo ay nagde-demand for more oxygen. Okay? So, nagde-demand for more oxygen. Kasi nga, may effort involved. Tumataas yung workload. Okay? So, nagiging demanding ngayon yung puso for more oxygen. Okay? So, ang tendency, pag may CSAP, ang demand ng oxygen by your heart really increases. However, this is the problem. Kaya nga nagkakaroon ka ng angina pectoris, okay? Dahil sa CAD, 'di ba? Dahil, bakit nagkakaroon ka ng angina pectoris? Dahil sa CAD. And I have mentioned earlier na sa CAD, ang problema, barado ang arteries. So, ang problema is, mababa, di ba? Mababa yung oxygen supply na dinadala ng coronary arteries. Kasi nga, barado ang arteries. So sa CSAP, ang nangyayari sa CSAP, sobrang demanding ang puso for oxygen. Kaso ang coronary artery, yung coronary arteries, it cannot meet or give the demand of oxygen supply in the heart. Kaya there is imbalance. Diba? Sobrang konti lang yung nasusupply ng oxygen during angina pectoris, during chronic stable angina pectoris, di ba? Mababa yung supply, oxygen supply. Okay? Then, sobrang demanding. Ang problema sa CSAP, sobrang demanding ng oxygen, ng puso, okay, for oxygen. So, nagkakaroon ng imbalance. Okay? Imbalance. Kaya, dahil sa imbalance na yan, the heart feels the pain or chest pain. Now, sa CSAP, recall, okay, recall ha, CSAP pa rin tayo, pathophysiology. Recall na ang chest pain, it can be relieved kapag nagpahinga. Okay? Bakit? Bakit kaya? Kapag nagpahinga, walang effort, okay, nagpahinga lang siya, bakit nawawala yung chest pain? Okay. Kasi, di ba kapag nagpahinga ka, kumusta yung effort? Lesser effort. Kung less effort, kumusta yung workload? Lesser workload. Tama? Thus, kung lesser workload for the heart, lesser yung oxygen demand ng puso. So, hindi masyadong demanding yung puso mo ngayon for oxygen. Kaya, somehow, nababalanse. Diba? Somehow, nababalanse ngayon. Kasi with lesser oxygen demand, lesser yung oxygen supply lang ang kailangan. And in the first place, diba? Basta CAD, lesser oxygen is being supplied by the coronary arteries to the cardiac cells, thus balancing oxygen supply and oxygen demand. Kaya nawawala yung chest pain kapag nagpahinga yung patient na may CSAP. Okay, so that is the reason why chest pain in CSAP can be relieved by resting. So, huwag kalimutan, sa CSAP, ang problema kapag nag-effort ka, napoprovoke, pwede mong ma-feel yung chest pain kasi nagiging demanding yung puso mo for oxygen. Taas yung oxygen demand. Now, let's proceed to Prince metal angina or variant angina. So, ibang kulay na lang. Ayan, pula. Variant angina. Ang problema ulit dito is may vasospasm, di ba? May vasospasm, constricted, may constriction of coronary arteries. Again ha, constriction. In the first place, constricted yung coronary arteries. Therefore, kung may vasospasm, constricted ang coronary arteries, arteries, saan related? Basta arteries, supply or demand, arteries, coronary arteries, constricted daw yung coronary arteries. So, ang affected is this supply. So, in the first place, sa variant angina, ang problema is sobrang mababa ang oxygen supply. Okay? Okay, again ha, ang problema natin sa variant angina, masyadong mababa. Sobrang mababa ang oxygen supply due to vasospasm, constriction of coronary arteries. Kaya kahit nagpapahinga, okay, or under resting yung tao, hindi na nga demanding, di ba, ang puso for oxygen supply, hindi na nga demanding. Pero dahil may constriction ng coronary arteries and sobrang mababa ang oxygen na nasusupply niya, as in salat sa oxygen. Okay? Kahit di na demanding ang puso for too much oxygen, so ang tendency, imbalance pa rin. Okay? May mismatch pa rin between oxygen supply and oxygen demand. Okay? Hindi pa rin na nagigive, namimit yung kailangan ng oxygen supply for that specific area ng cardiac cell. So, imbalance, pag may imbalance ulit, that's the time mafe-feel yung chest pain. Okay, that is why at rest, even at rest, nafe-feel pa rin yung chest pain with variant angina. So, in the first place, ito talaga yung problema sa variant angina dahil sa vasospasm, constricted yung coronary arteries, mababa na daan yung oxygen supply. Sobrang mababa yung oxygen supply. So, tandaan ha, tandaan, CSAP, ang problema, sobrang demanding, sobrang taas ng oxygen demand. In variant angina, mababa yung oxygen supplied by the coronary arteries. Okay? So, yan yung problema. Okay? For angina pectoris na types. Okay? So, since you have learned already the problem behind angina pectoris, for these two types of angina pectoris, okay, we will now solve the problem. Okay, this time, susolusyonan natin yung problema. Okay, susolusyonan natin yung problema sa CSAP. Ang problema sa CSAP, taas yung oxygen demand. Susolusyonan natin yung variant angina. Ang problema, sobrang mababa ang oxygen supply. So, goal natin ngayon is solusyonan. Okay, isolve ang problem sa angina with the use of drugs. Okay, so in general, ang main objective is dapat yung imbalance. Okay, ito yung main objective nato. 'Di ba nagkaroon ng imbalance sa supply at saka demand? Dapat ang main goal nato for therapeutic effect, okay? Dapat ang goal is mabalance. Okay? Mabalance nato ang imbalances, mismatch ng supply tsaka demand. I-balance nato, balance. Okay, with the use of drugs, the anti-anginal agent. So, una, CSAP. Okay, CSAP, ang problema again sa CSAP, ano sabi kanina? Ang problema sa CSAP, taas. Sobrang taas ng oxygen demand. Masyadong demanding yung puso. So, ang goal natin, yung goal ng gamot, okay, yung goal ng gamot, hoy, puso, wag ka naman masyadong demanding. So, iyahang i-decrease. Okay, natin mga drugs that will decrease oxygen demand. So, yan yung goal ng gamot for CSAP. Okay, example ng drugs that could decrease oxygen demand, we have beta blockers. Okay, beta blockers, somehow, di ba, na-encounter naman ninyo ang beta blockers, somehow, cardiac depressants ba sila? Cardiac depressants ba yung beta blockers? Yes. So, mababalikan natin yung MOA mamaya ng beta blockers. Kasi, di ba, negative inotropy. So, somehow, they depress the cardiac myocytes. Okay? Another is nitro-vasodilators. So, madadiscuss natin ngayon, okay, later, yung MOA ng nitro-vasodilators. And we have calcium channel blockers. Calcium channel blockers, particularly yung mga cardiac acting. Okay? Yung cardiac acting na calcium channel blockers. Okay? Kaya pwede, di ba, pag cardiac, heart-related, demand yung na-affect. Okay? So, dinadecrease nila yung oxygen demand. Okay? So, pwede siya gamitan to decrease myocardial oxygen demand. Kaya, I have mentioned sa lesson 1, under calcium channel blockers, di ba, dalawa yung pwedeng action niya. Pwede sila vasoselective na calcium channel blocker. Meron din tayong mga calcium channel blocker na cardiac acting. or considered as cardiac depressant. Okay? So, ayan. And for variant angina, ang problema dito is sobrang mababa, 'di ba, ang oxygen supply. Yun yung problema sa variant angina dahil sa vasospasm. Okay? Or constriction ng coronary arteries. Okay? So, ang problema is ang ugat. Very constricted ang ugat. So, ang goal ng gamot, okay, ang goal ng gamot dito is to dilate. Okay? Dilate or relax the coronary arteries. Kasi yun yung problema sa variant angina, yung arteries constricted, may vasospasm. Siyempre, ang kailangan natin ng gamot is yung nagpapadilate, nagpaparelax ng coronary arteries. Therefore, kailangan natin ng vasodilators like nitrovasodilators. Okay, yung mga nitrates. Okay? And of course, the vasoselective. Na-discuss ko yung mga vasoselective, di ba? Na CCBs. Okay, pag sinabing vasoselective, it targets the arteries. Okay? So, with these agents, we expect that they could dilate coronary arteries. So, kung dilated yung coronary arteries, we suppose na they could increase, di ba, blood flow, they could increase oxygen supply. Okay? So, they could manage. It can be used to manage variant angina or yung, ano yung other name ng variant angina? Prince metal angina. Okay? Now, for the general drug action, in angina, there are drugs or agents that can, okay, again, they can reduce myocardial oxygen demand. Okay, how can they reduce myocardial oxygen demand? By altering the following determinants of oxygen demand. Okay, so unsa man yung mga determinants? We have heart rate, ventricular volume, blood pressure, contractility. Yung ventricular volume dito, related yan sa amount ng blood that enters the heart. Sa may other term, amount ng blood that enters the heart, that is the preload. So, mababalikan din natin yung concept ng preload later. Okay? Another action, yung drugs naman ng or agents that increases oxygen supply. Okay? Yung drug action, there are also agents that increases the delivery. Okay, the delivery ng myocardial oxygen by coronary arteries. How? Via reversing. Nire-reverse nila yung vasospasm. So, pag na-reverse yung vasospasm, ultimately, there is vasodilation. Okay? So, yan yung general drug action sa angina. Okay? Now, let us discuss the classification of anti-anginals. So, based on this outline. So, ito yung magiging outline natin for the discussion natin for anti-anginals. Okay, so we have vasodilators. Vasodilators, of course, they dilate. Okay, they dilate the blood vessels, specifically the arteries. And then, for the non-vasodilators, walang effect sa ugat. Okay, asa sila ga-target? They target the heart. Okay? Kumbaga, depressant sila ng heart. Okay? So, pasok dito yung beta blockers. Okay? Sige. Start na ta. Summarize natin ang MOA, mechanism of action of these agents. So, let's start with vasodilators. Okay? So, yung discussion ko sa mechanism of action in a summary form ha, kasi familiar naman kayo sa beta blockers. So, summarize ko lang, calcium channel blockers. And somehow, meron na kayong idea sa mga direct or pure arteriolar vasodilators. Si nitrovasodilators kasi, isa siyang pure, diba? Pure arteriolar vasodilator. Okay. Vasodilator tayo ha. Now, when we talk about vasodilators, apparently, they target the coronary arteries. Okay? So, they target the coronary arteries. And of course, somehow, in some cases, also the veins. Okay? Also the veins. Okay? So, focus tayo ngayon sa coronary artery nila na action. In connection to that, balikan natin yung lecture ko regarding vasodilators. Okay? Naalala ba to? Yung illustration na to? Okay, naalala ba? Last time, okay, pag-discuss na ako sa vasodilators, na ano siya nga illustration. Medyo nalahi lang ang color dire, medyo nag-zoom lang siya. Okay? Pero ito pa rin 'yun. Parehas lang. Okay? So para dili mo mahilo, ako ang tungaon. Okay? Tungaon ako ang portion, okay? Tungaon ako ning red, kanang na red arrow. Ayan. So ana. So para dili mo mahilo. So dito sa left side, kanin diri nga left side, okay? May kinalaman dito yung CCBs. Okay, calcium channel blockers. Ayan. Sa right side naman, dito naman yung mga nitrovasodilators. Okay, so ito yung mga nitrovasodilators. Okay? So, start tayo. Start tayo sa CCBs. CCBs or calcium channel blockers. Naalala ba yung sa discussion ko sa CCBs, yung calcium channel blockers? Or sa calcium channel muna. Naalala ba yung trigger calcium? So, ito yung trigger calcium. And with trigger calcium, di ba, na-activate ultimately ang, anong enzyme yun? Ultimately, kapag may entrance ng trigger calcium sa loob ng cell, na-activate ultimately ang kinase enzyme or the myosin light chain kinase enzyme. Therefore, with kinase, ano yung ginagawa ng kinase na to? Ano yung ginagawa niya sa myosin light chain? Nadadagdagan ng phosphate group ang myosin light chain. Ibig sabihin, with kinase, di ba, with kinase, yung group na dala-dala niya, it will transfer phosphate group. So, si MLC dito, myosin light chain, it will undergo phosphorylation of MLC. Okay? So, kung may phosphate na added sa MLC, that will ultimately result to contraction. Naalala? Yan yung sa L-type calcium channel. Tama? So, ngayon, ano yung ginagawa ni calcium channel blocker? Blocker. So, binablock nila itong L-type calcium channel. So, block yung L-type calcium channel. Kaya nga, sabi natin nga ang CCBs, they are vasodilators. Kasi, walang contraction na mangyayari, kundi opposite, vasodilation or relaxation. Okay, that is for the CCBs, MOA niya. For nitrovasodilators naman, yung mga nitrates, once administered in the body, again ha, dito na tayo sa nitrovasodilators na MOA. MOA, mechanism of action in general. For nitrates, once administered in the body, yung nitrates and nitrites, they are being converted to nitric oxide. Again, ang nitrites and nitrates, when administered in the body, sila mismo naka-convert into nitric oxide. So, tandaan ha, sila mismo precursor ng nitric oxide. Naalala ba yung effect kapag merong nitric oxide? Naalala, pag may presence ng nitric oxide, ano yung effect? Recall that it activates what enzyme? Guanylyl cyclase. And with guanylyl cyclase, kapag na-activate ang guanylyl cyclase, merong CGMP. Pag may CGMP levels, ano yung ginagawa ng CGMP? Sa myosin light chain phosphate, ano yung ginagawa ni CGMP sa myosin light chain phosphate? Meron siyang tinatanggal, di ba? Ano yung tatanggalin niya? Yung phosphate group. So, with CGMP, nagkakaroon ng dephosphorylation ng MLC phosphate. Tatanggalin niya yung phosphate and removal of phosphate group will result to MLC na lang, myosin light chain. So, kung MLC na lang, myosin light chain, that will cause relaxation. Kaya, nitrates, okay, nitrites, vasodilators. Okay? So, parehas lang ni siya nga pathway ha. Parehas lang nga pathway sa vasodilators. Only that, yung nitrates and nitrates, sila mismo ang naka-convert into nitric oxide. Okay? So, okay na tayo sa MOA, mechanism of action ng nitrovasodilators. Okay? Okay na tayo dito sa action ni nitrovasodilators, mechanism of action ng CCBs. Now, ang dipyridamol naman, isa din siyang coronary vasodilator. Bakit? Okay, ano ba yung ginagawa niya? Yung dipyridamol po, take note, ini-inhibit niya yung phosphodiesterase enzyme. Again, ini-inhibit niya yung phosphodiesterase enzyme. Phosphodiesterase enzyme, PDE. It inhibits. Therefore, makaklasify natin siya as phosphodiesterase inhibitor. PDE inhibitor siya. Now, ano ba yung role ng phosphodiesterase? Okay, nakita niyo siya sa illustration, yung PDE. No, asa man ang PDE sa illustration? 'Di ba? Naara ang phosphodiesterase. Okay? Now, ano muna yung role? Okay, bago si dipyridamol. Okay? Ano muna yung role ng phosphodiesterase? Ano yung role ng importance ng phosphodiesterase? Okay, isa siyang enzyme, yes. This is an enzyme that metabolizes CGMP. Tingnan yung pathway, di ba? There siya involved. Okay? Si phosphodiesterase, iyang gina-metabolize ang CGMP. It degrades, it inactivates CGMP, making CGMP inactive. Okay? Okay? Na-inactivate siya, forming GMP. Siyempre, kapag inactivated ang CGMP, etong pathway na to sa baba ng CGMP, it will not proceed. Tama? So, walang mangyayaring relaxation. Tama? Kasi nga, na-degrade, na i-inactivate ni phosphodiesterase ang CGMP. Okay? Now, with dipyridamol, i-insert na natin yung dipyridamol as vasodilator. Yung dipyridamol, ano yung ginagawa ng dipyridamol? They inhibit phosphodiesterase enzyme. And they-inhibit niya yung PDE. If inhibited ngayon ang PDE, kumusta ngayon yung level ni CGMP? Kumusta ngayon yung level ni CGMP? Okay, taas ang level ni CGMP, retained. Okay, thus, the pathway under CGMP will proceed. It will proceed causing, ultimately, relaxation. Okay? So, relaxation of arteries. Therefore, with dipyridamol, via inhibiting phosphodiesterase enzyme, isa siyang vasodilator. Kasi nire-relax niya ultimately yung arteries. Okay? So, okay na tayo sa MOA. MOA ng dipyridamol. Okay? So, gamit lang yung illustration na to, na-discuss natin yung tatlong MOA ng vasodilators. Now, let's proceed to the cardiac acting na beta blockers. Okay? Ayan. Cardiac acting na beta blockers. Okay, recall muna natin ha, ano yung response ulit ng pag na-activate ang beta receptor. Again, wala munang gamot. Okay? I-recall sa nato. Okay, recall sa nato. Ano yung response kapag na-activate itong beta-1 receptor? We're talking about the cardiac acting ha. Kasi yung beta-1 receptor, di ba, siya yung receptor ng beta-1 na makikita sa heart. Okay, beta-1 located siya sa heart. So, ito yung related sa topic natin, si beta-1 receptor. Kapag na-activate muna siya ha, discuss muna natin, kapag na-activate, na-stimulate yung beta-1 receptor in the heart, pag na-stimulate siya, di ba, positive inotropy. Okay, stimulate. Pag positive inotropy, it increases the myocardial contraction. Kasi nga, positive inotropy. Okay? Now, explain natin molecularly, okay, molecular level, paano nangyayari yung myocardial contraction, yung positive inotropy, yung contraction upon activation ng beta-1. Okay? Wala pang gamot ha, wala pang gamot. Okay? Discuss natin paano yung contraction na nangyayari with the activation ng beta-1 receptor. Okay. Kapag na-activate itong beta-1 receptor, di ba beta-1, naalala, isa siyang GS-linked receptor. Naalala? GS-linked receptor ang beta-1 receptor. Therefore, ano yung secondary messenger na mare-release kapag GS-linked receptor? Di ba nasi-stimulate yung enzyme ng adenyl cyclase? So, ano yung secondary messenger? Okay? Na nare-release with GS-linked receptor, CAMP. Okay? So, with activation of beta-1 receptor, that results to increase CAMP level. Okay? Again, that results to increase of secondary messenger, CAMP. Now, ang CAMP, tingnan lang yung pathway. Yung CAMP naman, responsible siya for the activation of the enzyme protein kinase enzyme. Protein kinase enzyme A. Okay? Enzyme A. Okay? Again, pKa enzyme, that stands for protein kinase enzyme A. Okay? Now, again ha, si CAMP, ina-activate niya yung protein kinase A na enzyme. Activation of this pKa, that results to opening of the L-type calcium channel. So, ito yung L-type. Naalala ba yung L-type calcium channel? L-type calcium channel. Okay? Again ha, it results to opening of L-type calcium channel. Now, naalala yung function ng L-type calcium channel? Somehow may idea na kayo. Pag madunggan ng L-type calcium channel, naana mo yung idea unsa ang proceeding na mga mahitabo. Diba? So, ano yung mga posibleng mangyari upon opening L-type calcium channel? Diba? Itong trigger calcium, so may trigger calcium, makakapasok siya. It will enter. Pag nakapasok na yung trigger calcium, alam nyo na yung end result. Ano yung end result? Pinaka-end result kapag nakapasok yung trigger calcium sa smooth muscle. Okay? That will result to contraction ultimately. Kaya, kapag na-activate yung beta-1 receptor, nagko-contract. Diba? Yung cardiac myocyte. Positive inotropy. Diba? Positive inotropy. Ibig sabihin, na-stimulate. Okay? Na-stimulate ang puso. Okay? Cardiac myocyte. Na-stimulate yung puso upon activation ng beta-1. Now, ipasok natin sa story ang beta blockers. Ipasok natin sa story yung beta blockers. So, gamot na. Si beta blockers, ano yung ginagawa niya? Binablock niya yung beta-1. Ibig sabihin, it competitively blocks the binding of norepinephrine, yung neurotransmitter or ligand na dapat mag-bind sa beta-1 receptor para ma-stimulate yung beta-1 receptor. Okay? So, kapag na-block ang beta-1 receptor, dili na makabind karon ang norepi to its receptor. Kung dili siya makabind sa beta-1 receptor, no activation of beta-1 receptor. Thus, walang CAMP produced, walang L-type calcium channel sarado. Therefore, itong trigger calcium, it cannot enter. Tama? It cannot enter, kaya walang release. Okay? Walang release of sequestered calcium ion from the sequestered from the SR. Okay? So, hindi mare-release yung mga sequestered calcium from the SR or ano yung SR? Di ba sarcoplasmic reticulum. So, ano yung magiging net result? Kapag walang contraction, opposite ng stimulation, magkakaroon ng cardiac depressant effect. Excuse me. So, walang stimulation. Depressant effect. Okay, sa puso. Depressant. So, yan yung mechanism of action ng beta blocker. Kaya yung nakalagay, di ba yung nakalagay dito, yung classification as an anti-anginal, si beta blocker is non-vasodilator. Kasi nga yung action ng beta blocker is myocardium. Okay? Gina-depress niya yung myocardium. Hindi stimulated, kundi, ayan, depress. Okay? Ibig sabihin, meron siyang cardiac depressant activity pag na-block yung beta-1 receptor in the heart. Okay? So that is for the general mechanism of action ng mga drugs. Okay? Now, okay na tayo sa MOA ng mga drugs. Okay? Okay na tayo sa general MOA ng mga anti-anginals. Okay? Pero ang tanong, ano yung relevance ng mechanism of action nila for the management of angina pectoris? Yes, inyuhan ng nastudihan, okay, ganito, may vasodilating effect, okay, binablock nyo ito, kaya may vasodilating effect. Ayan, so alam nyo yon yung general mechanism of action nila. Pero ang pangutana karon unsa man ang iyahang importance, unsa may importance ato sa ilahang MOA in the management of angina. Okay? Ano yung magiging relevance ng mga effect na yun? I-relate nato karon ang mechanism of action nila, how these agents can be used to manage angina, yung dalawang klaseng angina. Okay? So let's begin with nitro vasodilators. Okay? So yung mga nitrates, okay, nitro vasodilators, they are also known as organic nitrite, organic nitrates. So I have mentioned earlier na once ma-administered sila in the body, yung nitrates, once ma-administered sila, they are being converted into nitric oxide. Again ha, once ma-administered ang nitrates, sila mismo, they are being converted to nitric oxide. Okay? Magkaiba yun sa na-discuss kong release ng nitric oxide under sodium nitroprusside. Diba? Kasi sa sodium nitroprusside, ang nangyayari, nag-e-induce sila ng release. Tinitrigger lang nila yung release ng nitric oxide. Kaya may relaxation effect. Si nitrates, okay, they are being formed. Okay? Napoproduce sila mismo into nitric oxide. So, precursor sila, source sila ng nitric oxide ngayon. Source sila ng nitric oxide. Okay? Kaya, as a net result, okay, pag may nitric oxide, okay, na-induce yung level na nitric oxide, yung levels of CGMP taas, resulting to relaxation din. So, almost the same. Magkaiba lang yung initial way. Kasi yung sodium nitroprusside, tinitrigger nila yung release ng nitric oxide na meron na sa vascular smooth muscle. Gina-trigger nila. Ang organic nitrates, sila mismo ang precursor. Okay? Ang source. Okay? So, ayan. So, again, upon intake of organic nitrates, nagiging nitric oxide sila via the enzyme nitric oxide synthase. Okay? And to activate this enzyme, Of course, it needs cofactor, di ba? Basta mga enzyme gani, useless ang mga enzyme kung walay cofactor. So specifically, this includes cofactor containing thiol groups. Okay, thiol groups. Kaya nga, basta nitric oxide synthase, they are considered to be thiol requiring enzyme. Okay? Thiol requiring enzyme. So, yan yung fate ng organic nitrates in which net effect is relaxation, vasodilation. Now, ano ngayon yung relevance nito sa anginal attacks? Okay. Tandaan na when we talk about nitrates being used as anti-anginals, meron silang dalawang posibleng effect. Okay? Meron silang dalawang posibleng pharmacological effects when nitrates is being used as anti-anginals. And each of this effect, dose-dependent. Again, each of that effect, dose-dependent. Ibig sabihin, yung pharmacological effect ng nitrite, it will depend on the dose being administered by the patient. Okay? So, dose-dependent. So, pag low dose ng nitrate, okay, pag low dose ng nitrate, iba yung effect. Kapag high dose naman, later na slide, iba din yung effect ng nitrates. So first, let's have the effect, pharmacologic effect ng nitrates at low dose. Okay? So example, nitrates given at 5 milligrams sublingually administered na ISDN. Then we also have another low dose of nitrates sublingually administered din, the NTG. Yung ISDN, NTG, specific example na sila ng nitrates. I will introduce them later. Yung ISDN particularly, yan ay isosorbide dinitrate. Yung NTG, yan yung nitroglycerin. Okay, so specific example na sila ng nitrates. Okay? So focus muna tayo sa pharmacological effect nila if given at low dose. So at low dose at low dose. Ano yung PICOL effect ng nitrates? Take note, peripheral venodilation. Peripheral venodilation at low dose. So i-relate natin ang effect na to. How can it be beneficial to angina condition? Okay, pag sinabing venodilation, obviously, di ba dilated or relaxed ang veno? Relaxed ang veins. Okay, veins. So, relaxed. Kapag dilated ang veins, we expect na ang blood reservoir or stored blood held by the veins ay increased. So, more blood reservoir. Okay? More blood reservoir sa veins. Ayan. So, kung ito yung veins, since dilated, more blood reservoir. Diba kapag reservoir, ito yung related sa capacitance. Tama? Capacitance. Ayan. So, again ha, kapag more blood reservoir, dilated yung veins, ibig sabihin, taas yung capacitance. Okay? Now, kapag taas yung capacitance, dahil dilated ang veins, kumusta ngayon yung, kumusta ngayon yung dugong pabalik into the heart? Kumusta ngayon ang dugong pabalik sa heart kapag dilated yung veins? Kumusta yung venous return, less or more? Kapag veins ay relaxed ang veins, wala masyadong pressure. So, ang dugong pabalik is lesser. Okay? Kaya, baba ang, ano yung affected? Yung amount ng blood na pabalik. Baba yung preload. Okay? So, decrease in preload. Therefore, lesser. Pagbaba, di ba ang preload? Lesser ang effort ngayon ng heart to welcome the incoming blood. Kasi konti lang naman yung preload, lesser yung kailangan na effort ng heart to welcome the incoming blood. Thus, if less effort, kumusta yung workload? Kung less effort, kumusta yung workload? Workload, kapag less effort, less workload. And finally, if less workload, the heart will need lesser oxygen requirement. So we can conclude na pag may peripheral venodilation, kapag ang veins ay dilated, the heart is not so demanding, okay, for oxygen. Okay, so with low dose of nitrates, decreased yung oxygen demand ng heart. So, tandaan ha, the cardiac myocyte will lessen its oxygen demand. Okay? So, ayan. Now, with this effect, via decreasing oxygen demand, merong isang type ng angina na pwedeng ma-manage with this pharmacological effect. Okay? Anong klaseng angina yon? Ang posibleng ma-manage via decreasing oxygen demand. Dinedecrease yung oxygen demand. Is it effort or Prince metal angina? Effort or Prince metal angina? It is, yes, effort angina or CSAP. That is why basta low dose, take note ha, basta low dose of nitrates, they are used for the management of CSAP or effort angina. Okay? Again, okay? The reason, it is because at low dose, may peripheral venodilation. Pag may peripheral venodilation, ultimately, nade-decrease yung demand, oxygen demand, very good for the management of CSAP. Kasi ang problema sa CSAP, taas yung oxygen demand. So, pwede gamitin at low dose yung nitrates for CSAP. Now, ano naman ang pharmacological effect ng nitrates kapag high dose? Okay, proceed tayo sa high dose na. At high dose, example, at high dose na IV infusion. Ang effect ng nitrate is additional arteriolar vasodilation. Okay, again ha, basta high dose, example IV infusion, high dose, ang effect is arteriolar or coronary artery vasodilation. So this effect tells us na ang coronary arteries are being relaxed. Di ba? Kasi may vasodilation. So, yung coronary arteries, relaxed, dilated. So, may coronary artery vasodilation. Now, kapag may dilation of coronary arteries, kumusta ang supply ng oxygen kapag dilated? Yung coronary arteries, kumusta ang supply ng oxygenated blood being delivered by coronary arteries, more or less dilated? Okay. More oxygen supply, okay, to the cardiac cells. So, taas ang oxygen supply, okay? Kasi 'di ba pag supply related sa, anong sabi ko, coronary arteries. So, pag coronary arteries dilated, ang affected is the supply. Okay? So, ayan. So, via increasing oxygen supply here, meron ding isang type ng angina na pwedeng ma-manage, okay, with this particular pharmacological effect, and that is Prince metal. Okay, Prince metal angina. Okay, so take note, at high dose of nitrates, it causes coronary artery vasodilation, increasing oxygen supply. Ayan ha, so pwede siya gamitin for Prince metal angina. Kasi ang problema sa Prince metal angina, mababa masyado yung oxygen supply. So at higher dose, pwede ang nitrates. Kasi yung effect, increase oxygen supply. So that's why dose-dependent ha ang pharmacological effect ng nitrate. So tandaan, at low dose, para saan? Angina pectoris, CSAP, effort angina. At high dose for Prince metal angina. So yan yung reason. Okay, yan yung reason, yung kakadiscuss ko lang, bakit sa slide na to kanina, 'di ba, excuse me, sa slide na to kanina, sa general objective ng anti-anginals, kung mapapansin nyo, for CSAP, may nitrates. Okay, for CSAP, may nitrates. For variant angina, may nitrates din. Variant angina, may nitrates din. Kasi, for CSAP, ang nitrates at low dose, bababa, 'di ba? Napapababa ang oxygen demand at low dose. For Prince metal, ang nitrates at high concentration, okay, napapataas ang oxygen supply. Same with calcium channel blockers, 'di ba? Na-discuss ko last time. Meron tayong calcium channel blockers na cardiac acting. Okay? Basta cardiac acting, cardiac, then yun related sa demand. Okay? Basta, ang CCBs is vasoselective. Okay? So, yan yung related naman sa arteries, vessels, ugat. So, nag-i-increase ng oxygen supply. Kasi pag supply, arteries. Di ba? Coronary arteries. Okay? So, ayan. So, let's have the other effects naman. Aside from the anti-anginal activity ng nitrates, meron din silang other effects. Okay? So, ayan. So, basically, yung mga nitrates are vasodilators, di ba? Vasodilators sila. Kaya naman, meron din silang relaxation effects sa other smooth muscles sa katawan. Okay? Why? Due to increased CGMP. Kasi di ba with nitrates, tinataas nila yung CGMP level. So somehow, meron din silang relaxation effects sa some other smooth muscles ng katawan. Example, relaxation in the bronchi, relaxation in the GI tract, gastrointestinal tract, sa biliary tract, sa genitourinary tract. Okay? So, ayan. And, paki-take note na ang relaxant effect ng nitrates in this smooth muscles, brief lang. Very brief. Mabilis lang. Kaya, it won't really provide clinical benefit for a long duration of time if ang nitrates ginamit for relaxation of this smooth muscles. Okay? And also, aside from this effect ng nitrates sa mga peripheral smooth muscles, meron din siyang relaxant effect ang nitrates sa corpus cavernosum. This is among men ni siya ha, among men. Kasi yung corpus cavernosum, this is particularly found in the penile tissue. Okay, particularly with nitrates, okay? With nitrates, relaxation of this smooth muscle, yung corpus cavernosum, relaxation of this smooth muscle results to, take note, of course, vasodilation. Therefore, kung dilated to, okay, kapag dilated, yung smooth muscle, yung corpus cavernosum, smooth muscle, more blood will flow in the vessels of the penis. Kaya, ano yung net result? Okay, kapag more blood, that will cause erection. Okay? So, gi-introduce na ako ni siya nga effect ni nitrates kasi mamaya may madediscuss tayong significant drug interaction na kailangan yung tandaan because it may cause health risk sa men patient. Okay? Health threat sa mga lalaki. So, pakitandaan itong effect na to ha, ng nitrate sa corpus cavernosum smooth muscle vasodilation. Okay? Now, moving on, aside from vasodilating effect, meron din silang posibleng effect affecting platelets. Okay? Causing decreased aggregation. Okay? When we say decreased aggregation, this means yung nitrates can potentially cause bleeding. Okay? Potential lang ha, potential. Meron lang siyang potential possibility of causing bleeding. Pero the same thing, brief lang din yung action niya, mabilis lang din. Okay? So, medyo hindi na natin siya napapansin. Okay? And finally, may effect din siya causing methemoglobinemia. Particularly, this is observed by the particular nitrite, yung amyl nitrite. May introduce natin to later. Okay? Nitrite. Ayan. Okay? So, these are the pharmacological effects ng nitrates. Again ha, yung nitrates, mainly, they are used as anti-anginals. Oo. They have, and which, kung used as anti-anginals, dose-dependent. Okay, dose-dependent. And these are the other pharmacologic effects ng nitrates. Now, let's proceed to okay. So, ito yung sinasabi ko kanina na with the use of nitrates, meron siyang significant drug interaction when used together with phosphodiesterase 5 inhibitors. Again, yung nitrates, when concomitantly administered together with phosphodiesterase 5 inhibitors, merong significant drug interaction na kailangan yung tandaan. Okay. Na PDE5 inhibitors, example dito ay yung sildenafil, tadalafil, vardenafil. Okay, so ito yung examples ng phosphodiesterase 5 inhibitors. In general, ang mga phosphodiesterase 5 inhibitors, they are erectogenic. Okay? They are erectogenic. Ibig sabihin, these agents causes penile erection. Okay? Erectogenic. Kaya ginagamit sila for the treatment of erectile dysfunction. Okay? Now, ang tanong, how can these agents cause these effects na somehow kaparehas ng other effects ng nitrates, which is penile erection din? Okay? So, let's find out bakit meron silang activity na ganito. Okay? So, these agents are said to be phosphodiesterase inhibitors. Ibig sabihin, okay, by the term pa lang, it suggests na they block the enzyme phosphodiesterase 5. Okay? Pero ano nga ba yung importance ng phosphodiesterase 5? Bakit kapag na-block siya, merong ganutong effect yung sildenafil, tadalafil, vardenafil? Okay. Naalala ba yung function ng enzyme phosphodiesterase kanina? Yung na-mention ko, yung action ni dipyridamole. Di ba si dipyridamole isa siyang phosphodiesterase inhibitor in general? Parang ganito din. Pero yung PDE5, makikita siya sa cavernosome, corpus cavernosome. Phosphodiesterase enzyme din siya. So, ibig sabihin, yung role in the penile tissue, in the corpus cavernosum, ang role ng phosphodiesterase 5, same. Gina-degrade niya ang CGMP into its inactive form GMP. Okay? So, yan yung ginagawa ng phosphodiesterase 5 enzyme. Okay, gina-metabolize niya ang CGMP, gina-inactivate niya into GMP. Okay? Kaya, baba ang level. Di ba? Bababa ang level ng CGMP. Okay? Hindi magpapatuloy ang pathway under CGMP. Ano ba yung end result ng CGMP? Okay? Yung kapag may enough level ng CGMP, sa smooth muscle, ano yung end result? Di ba mayroong relaxation, mayroong vasodilation. And for penile tissues, Penial tissues, pag may vasodilation, ano yung effect? Diba? Erection. Okay, so hindi to magpapatuloy kung na-metabolize si CGMP. Okay, with the presence ng phosphodiesterase 5 na enzyme. So, no penile erection yung mangyayari. So, yan yung nagagawa ng enzyme phosphodiesterase 5. Kasi na-degrade. Okay, imbis na CGMP, ito yung dumadami. GMP, which is inactive. Okay, inactive siya na metabolite. Now, ipasok natin yung phosphodiesterase inhibitors like sildenafil. So, yung ginagawa nila, they block, okay? They block the phosphodiesterase 5 in the penial tissue. Okay? By blocking the phosphodiesterase 5, kumusta ngayon yung CGMP? CGMP will not be metabolized. Activated pa rin siya. Mataas pa rin yung level niya. Therefore, CGMP end result ng CGMP, vasodilation causing penile erection. Kaya nga yung mga sildenafil phosphodiesterase 5 inhibitors erectogenic. Okay? Ultimately, ang mga gamot na ito. Particularly si sildenafil, ang sildenafil, particular brand niya, common brand niya, si Viagra. Okay, Viagra. So, kung familiar mo sa Viagra, ito yung reason bakit may ganoong effect si Viagra. Okay? Now, take note as well na kung may dilating effect sila sa smooth muscles ng penile tissue, samot na sa vascular smooth muscles. Siyempre, hindi lang naman penile tissue smooth muscles yung magdadilate kapag nag-take ka, di ba? Systemic man ang effect ng drug. Therefore, at somehow, merong mga madadilate na mga peripheral vascular smooth muscle. So, in general, take note ninyo ha, in general, yung sildenafil phosphodiesterase inhibitors, blood vessel acting din sila. Blood vessel acting din sila. Okay? Kasi nga, napapataas nila yung level ng CGMP via inhibiting phosphodiesterase 5. So, may effect din sila sa ugat causing vasodilation. Ayan. So, take note, meron din silang vasodilation activity. Now, pag may vasodilation, kumusta ngayon yung blood pressure? Kumusta ngayon yung blood pressure kapag gumamit ka ng gamot na ito? Taas or baba? Siyempre, vasodilation, baba yung blood pressure. Kaya merong hypotension. Okay? May hypotension effect yung mga phosphodiesterase 5 inhibitors. Okay? Kaya nga, yung mga lalaki, mga elderly men, like 50 to 60 years old, na may impotent na nagtitake ng sildenafil, itong sildenafil, for instance, always gina-remindan silang doctors na, sir, maaaring bumaba ha yung blood pressure ninyo upon taking sildenafil. Unless ang patient wala na niagi og doctor, gihatagan ra siya og supply og Viagra sa iyang amigo, amiga, or nagpalit ra siya over the counter. So most of them, ang alam lang nila, pang-pa-erect lang yung sildenafil. Hindi sila aware na pwedeng bumaba yung blood pressure nila. And syempre, matatanda na sila. Usually, di ba pag matatanda, may maintenance drug yan. May maintenance drug ang mga yan. Halimbawa, may mga hypertensive drugs silang tinitake. Example, meron silang drugs na tinitake like nitrates. Okay? Nitrates, isang vasodilator. So we expect there could really be a significant drug interaction here. Kaya pwedeng magkaroon ng severe hypotension when taking both drugs. Kung sinabay mo i-take ang both drugs, very risky. Very at risk yung mga matatanda na yan sa mga cardiovascular problems. Okay, kung concomitant ang pag-take sa nitrates sildenafil kapag sinabay, ha? Don't get me wrong, ha? Don't get me wrong, hindi naman pinagbabawal talaga yung pag-take ng sildenafil. Okay? Sa any adult, sa any elderly males, lalo na sa mga matatandang lalaki, okay, under maintenance hypertensive, hindi siya pinagbabawal, okay lang naman mag-take sila. Kasi syempre, 'di ba, for, for pleasure purposes nila 'yan, 'di ba? Di natin ipagkakait 'yan sa kanila. So para maiwasan natin yung drug interactions upon taking nitrates with sildenafil, mayroong recommended kinetics dyan. Mayroong recommended kinetics. Okay? So, ang pharmacokinetics dyan is at least 6 hours ang interval ng gamot. Ibig sabihin, halimbawa, okay, maghatag ko scenario ha. Example, ang matandang lalaki, meron siyang boxing action at 9 p.m. ng gabi. Okay, so nagplano siya, okay, mag-boxing ko. Kabalo na maunsa ng boxing action at 9 p.m. ng gabi. Okay, dapat, ang mahitabo karon dapat i-take niya ang nitrates at 3 p.m. Okay? Kay 9 p.m. naman siya plano sa 9 p.m. na boxing, dapat 3 p.m. pa lang, i-take niya ang nitrates. Pila man na ka-hours? Diba, 6 hours man na siya. Para within 3 to 9 p.m., diba, from 3 to 9 p.m., nagwe-wear off na yung effect ng nitrates. Okay? So, by 9 p.m., sildenafil naman yung i-take niya, ready. Para sildenafil naman yung ready for action. Kung saan man siya gagamitin. Okay? So, yan yung kinetic dyan para maiwasan yung severe hypotension. Delikado yung severe hypotension, ha? Pwede na siya makamatay sa pasyente. Okay, so that is for the pharmacokinetic. So please take note of this drug interaction. Now proceed tayo sa mga examples ng nitrates. We can actually classify nitrates based on duration of action. Okay, based on duration of action, we can actually classify them as very short acting. So we have the amyl nitrite. Okay, take note, this is the only nitrite administered via inhalation. Okay, administered via inhalation, amyl nitrite. For short-acting naman, we have ISDN. So, ito yung isosorbide dinitrate. Isosorbide dinitrate. Yung NTG nitroglycerin. So, mga short-acting, take note, both are sublingually administered. Sublingually administered. Siyempre, di ba? Ano yung naaalala nyo sa DDS kapag sublingual? Faster, di ba? Yung onset ng action. Kaya, short-acting, basta sublingually administered. Kapag intermediate acting naman, ganun din, ISDN, nitroglycerin, but this time, yung ISDN, regular tablet form. Tablet form siya, so orally taken. Okay? Then, for nitroglycerin, sustained release tablet, then tablet. Okay? Sa tablet, di ba, yung onset ng action niya, hindi agad-agad. Kasi pag tablet mo, agi pa biya, nag-LADMER. LADMER, liberation, absorption, distribution ng active drug, nantod ba metabolize siya. So, daghan pa siya agian. Kaya, hindi agad-agad yung onset ng action. Kaya, intermediate acting. Okay? Then, long-acting naman, long-acting example is ISDN SR tablet. Ganun din, by mouth, taken. Isosorbide mononitrate. And nitroglycerin nga transdermal patches. Ma-appreciate din ninyo ng mga drugs, mga nitrovasodilators, if mag-internship na mo sa hospital. Okay? Makita, dali ra kayo na sila makita sa hospital. Always ni sila. Okay? Sa hospital, ma-encounter ninyo. Okay? For isosorbide mononitrate, ang ato ang brand name ani nga common is yung Imdor. Actually, daghan. Pero ang pinaka-common, Imdor. Dayon sa isosorbide dinitrate nga sublingual. Sublingual is, so ito. Sublingual is Isordil. Yan yung mga common brands. Okay? So these are the examples of vasodilators. Okay? Next, for the clinical use. For the clinical uses of nitrates, first, of course, ginagamit sila as agents for angina pectoris. So, anti-anginal sila, used in the management of angina pectoris. Like, for instance, acute coronary syndrome. So, yung nitrates is via IV administration. Okay, yung nitrates via IV administration for acute coronary syndrome. For CSAP, ang dose, ng nitrate is at low dose. So, by mouth naman siya or as transdermal. Then for variant prinzmetal angina na ang mga nitrates, of course, since higher dose, basta higher dose, IV infusion gina siya. Mo gina tanan basta higher dose ani nga IV gina siya permi. Okay? Bakit bakit ba added with beta blocker? Bakit added with beta blocker? Ang IV infused higher concentration of nitrates. Why do you think? Okay. So, nga nila siya. Kapag Prince metal angina, di ba, yes, high dose ang nitrates given to patient. Now, balikan natin yung effects ng nitrates kapag high dose. Di ba, kapag high dose, ano yung effect? Ang effect ng nitrates, basta higher dose, merong arteriolar vasodilation. Vasodilation na siya ha, vasodilation. Yan yung effect, di ba? Main effect yun, basta high dose ng nitrates. Arteriolar vasodilated, relax ang coronary arteries. Now, kapag relax ba yung coronary arteries, okay, pag may arteriolar vasodilation ba, kumusta yung arteriolar pressure? Kumusta ang arteriolar pressure? Basta dilated yung arteries. Baba yung arteriolar pressure. Now, ang pagbaba ba dito ng arteriolar pressure ay madedetect ng baroreceptor? Do you think madedetect ni baroreceptor yung pagbaba ng arteriolar pressure? Ang decreased arterial pressure ba isang stimulus that could activate baroreceptor? Yes. Okay. So, recall na ang response ng baroreceptor ay negative response. Therefore, itong arteriolar vasodilation caused by nitrates at high dose will activate the sympathetic efferent pathways. Okay? So, kung activated yung sympathetic efferent pathways, ano yung magiging drawback? Resultant drawback, basta activated yung sympathetic pathway dahil sa stimulus na baba yung arterial pressure. Syempre, negative feedback si baroreflex, itataas ninyong arterial pressure. Ang negative, ang resultant drawback dito is reflex tachycardia. Okay? So, yan yung drawback, adverse effect, which is related yan sa baroreflex. The same concept na siya that I had discussed under antihypertension, yung sa pure arteriolar vasodilator, di ba? They causes a drawback of reflex tachycardia basta solo use therapy. Okay? And remember, yung nitrates at higher concentration, meron siyang arteriolar vasodilating effect. So, pag solo use, okay, solo use, walang kasamang beta blocker, that could really worsen the case or condition ng patient. Okay, so that is why added with beta blocker to mask, okay, to mask the reflex tachycardia na drawback. Kasi yung beta blocker, balik-balik, kung saan beta blocker, cardiac depressant, negative inotropy, so bradycardia yung activity niya. Okay, so dapat yun i-conceal. Kailangan nato ni i-mask. Sobrang need i-conceal ang reflex tachycardia. Kasi remember, kapag may tachycardia, ang puso is stimulated. Kung stimulated ang puso, 'di ba, magiging demanding na naman yung puso for more oxygen supply. So, ma-e-exacerbate tuloy yung angina, chest pain na sad, 'di ba? So, para ma-conceal, ma-mask yung adverse effect, kailangan ng cardiac depressant. So, good combination drug here is beta blocker, isang cardiac depressant. Also, yung mga nitrates, they are alternative in the management of hypertensive emergencies via IV infusion. Then add-on din sila in the management of congestive heart failure, particularly yung ginagamit dito for congestive heart failure na nitrate is yung ISDN. Naalala, ISDN together with hydralazine. Ako na siyang na-introduce, di ba? Under sa hydralazine na topic, na si hydralazine effective siya for congestive heart failure in combination with ISDN, isosorbide nitrate, isang nitro vasodilator. And wherein, asa ra ni effective na combination sa mga patient, African American patient. Okay? So, also, pwede din gamitin ang nitrate for acute pulmonary edema via TDDS. TDDS, that is transdermal drug delivery system. Or sublingual administration. And particularly, ang type ng nitrite for the management of cyanide poisoning, yan yung amyl nitrite. Okay? Amyl nitrite. Okay? Which is present, diba, si amyl nitrite sa cyanide antidote kit. Okay? So, these are the clinical uses of nitro vasodilators. Okay? Next is for the adverse effects. Okay? Adverse effects naman ng nitrates. First, we have tolerance. This is very common among nitrates, yung tolerance. Okay, wherein, when we say tolerance, nangyayari to when there is a continuous use of nitrates. Okay? When there is continuous use kasi of nitrates, there is a chance na later on, kapag nasanay na ka or na-immune na ka sa nitrates na effect, ang effect ng nitrates is no longer effective in you taking the drug. Minsan kasi sa mga gamot, hindi naman lahat, pero may mga gamot talaga na nagkukos ng tolerance. Kapag nagtitake ka ng gamot, lalo na kapag maintenance drug, ang first few doses very sensitive yung katawan natin with the responses caused by drug. Kaya, agad-agad, may effect sa atin for the first few doses. But time will come, upon continuous use, especially with nitrates, okay? Upon continuous use, yung initial effects na nafe-feel natin dati, upon taking that drug, wala nang epekto sa'yo upon continuous use. Kumbaga, nagkaroon na ng loss of response with a given regular dose ng drug due to continuous use over time. Okay, murag sa murag sa kape, kanang very sleepy na gid kaayo ka, very sleepy. Katag ako na gid kayo yung mata, pero kailangan din ako ni humanon. Okay, kailangan din ako humanon akong school stuff, work stuff. Okay, pero never ka nagkape. Never ka nagkakape. Okay, pero desperate na gid kaayo ka. Kailangan na gid ako magkape, dapat mahuman ako ni. Okay, so nagkape ka. Then sa first sip nimo, first time ka magkape, ikabantay mo sa first sip ninyo, a few sip ninyo sa coffee nga pure, ma-stimulate gyud diretso inyohang CNS. Kana kay first initial pa man nimo nga inom sa kape. Very sensitive ang atong katawan sa effects, pero kanang continuous na ka na magkape halos everyday, coffee, Starbucks, sa McDo nga coffee, unsa inyong nabantayan kung halos continuous na inyong pag-use every night na gyud nga mag-use ka og kape, dili na gyud nga naka-effective ang kape, di ba? Sa inyo due to tolerance. Okay? So, sa mga gamot na nagkukos ng tolerance, if it usually causes tolerance, example, sa nitrates, Okay? So, pag nagka-tolerance ka na, talagang itataas nyo yung next doses. Okay? If di na effective yung normal regular doses given to you, talagang itataas nyo to maintain the effect. Okay? So, yan yung problema with tolerance. Okay, next is vascular headache. This is also known as throbbing. Throbbing headache. Okay, throbbing headache. Very common ni siyang adverse effects of nitrates due to vasodilation effect. Okay, so headache. Then, Monday disease. Monday disease, kung ano siya, kanang historical, yun. Na siya history, nga nung tawag siya as Monday disease. So, may dahilan bakit Monday disease ang term. So this disease is particularly related or characterized with having headache at saka tolerance din. Okay, tolerance. So saan ba galing ang term na Monday disease? Okay, saan ba galing yung term na Monday? This is based ni siya sa nahitabo sa usa ka manufacturing firm ng bomba. I'm not sure kung asa nga country ha. Basta kay ang Monday disease ang sa akong pagkahibalo based ni siya sa nahitabo sa usa ka manufacturing firm ng bombs. Wherein yung mga workers doon, yung mga workers in that firm, syempre ang duty 'di ba is Monday to Friday. So off dayon then Saturday, Sunday ang off. Gakatingala sila nga taga-duty nila sa first day ng week, sa Monday, gakatingala sila every Monday yun. Sumasakit ulo nila. Okay, so headache. Sumasakit long ulo nila, labad gyud ilang ulo. Then Tuesday, naagi hapon, pero medyo nawala-wala na hanggang Wednesday, wala-wala na po. Hantod makawala, magkaanam siya wala-wala. Okay? Then, pasok ulit. Monday. Okay? Pasok ulit Monday, sakit na po, ilang ulo. Then Tuesday ulit, medyo nawawala. Then cycle. The cycle repeats. Okay? Siyempre, off sila Saturday. Sunday off. Off sila Saturday, Sunday. So, may withdrawal effects sa kung ano man yung nagkakos ng sakit ng ulo. 'Di ba? Bakit kaya? Bakit kaya sumasakit yung ulo nila every Monday? Okay, so ilahang nahibalaan, they have found out na dahil pala yun sa nitrates. Kasi in manufacturing bombs, yung main ingredient, active ingredient sa pag-manufacture ng bomb is nitrates. Take note nyo ha, nitrates at very, very high concentration, explosives ang use ng nitrates. Okay, explosives ang mga nitrates at super high concentration. Kaya pala every Monday, di ba? Every Monday, syempre, initial exposure nila with nitrates. So, sensitive ang katawan nila. Nafe-feel talaga nila yung adverse effect. Okay? Kaya sumasakit yung ulo nila. Then, madugay-dugay, okay, along that 5 days na duty nila, Monday to Friday, magkaanam. Okay, magkaanam sila immune sa effect ng nitrates. So, dayon walay duty dayon sa Saturday, Sunday. So, may withdrawal effect. Duty na po sa Monday, okay, initial exposure na po nila. So, sakit na po nilang ulo. Then, gradually, Tuesday to Friday, nawawala-wala. Gaka-immune sila. Okay? Kumbaga, so yun yung tolerance na part. Nagkakaroon sila ng tolerance due to sequence exposure to nitrates. Kaya, ang tawag is Monday disease. Monday disease. Next is reflex tachycardia. So this effect is experienced with higher dose ng nitrates kasi pag higher dose yung effect is arterial vasodilation. Okay? Then to mask this adverse effect, drawback, meron tayong beta blocker, added with beta blocker ang nitrates. Then postural hypotension and then methemoglobinemia that causes hypoxia. So, kaning methemoglobinemia, very common na siya sa amyl nitrite. Okay, so hapit na mahuman. Okay, hapit na. Okay, so let's proceed to beta blockers. This is another anti-anginal. Okay, take note na ang mga beta blocker, ano sabi ko, cardiac depressant. Okay, cardiac depressant sila. And they are not acting in the blood vessel. Okay, cardiac depressant. Ano yung related sa cardiac? yung demand. Okay? So, sa CSAP, 'di ba, sobrang taas ng oxygen demand. That is why yung beta blockers, ginagamit sila as first line maintenance treatment for CSAP kasi nga cardiac acting sila. Cardiac acting. And remember, ang problem 'di ba sa CSAP, masyadong demanding ang puso for oxygen. So ang gagawin ng beta blocker is to decrease the myocardial oxygen demand. Kasi nga ano sa man ang beneficial effect ni beta blocker, 'di ba? Negative inotropy, so lowering oxygen heart. Okay, lesser ngayon, reduce ngayon blocker. So first line maintenance treatment yung beta blocker for CSAP. Okay? Then for this part, na-discuss ko na to, di ba? Yung beta blockers, they are given caused by nitrovasodilators at higher dose. Yung patient who has ongoing angina pectoris, never give them beta blockers as single agents because meron din compensatory mechanisms. And for calcium channel naman, remember, we have two classes, di ba? We have two classes of CCBs. Napod tayo non-DHPs. Ayan. Ang katong mga DHPs, katong mga dipins, naalala, vaso-selective sila. Okay? So, vaso-selective. Yung mga non-DHPs, verapamil, diltiazem, meron silang action sa heart. Okay? Meron silang action sa heart. So, mayroon silang cardiac effect. Okay? Yung mga non-dihydropyridine. So, dahil dalawa yung classification ng CCBs, merong DHPs na sa arteries, nag-affect, meron din sa heart. So, dalawa yung posibleng applications ng CCBs. Okay? So, may CCBs that can reduce oxygen demand of the heart. So, we have the verapamil. Okay? Verapamil dito. Kasi di ba pag oxygen demand, yan yung related sa heart. So, kailangan na DHPs. And remember, si verapamil, this information, pinapababa niya yung oxygen demand. For CSAP siya, for CSAP. Okay, CSAP. Kasi nangyari sa CSAP, sobrang taas yung oxygen demand ng heart, ng puso. Verapamil, action niya is sa heart, papababa niya yung oxygen demand. Ayan. Okay, variant angina, which relieves vasospasm or which relieves the constriction of artery. So, yung mga CCB angina is yung oxygen supply. Saan related yung supply? Sa arteries. Sa arteries, coronary arteries. So, kailangan ng DHPs dito. Yung mga DH selective sila. Okay? Specifically, they act on the arteries. Dinadilate nila yung arteries. Okay? Then, for the specific descriptions about CCBs, na-discuss ko na to kanina, diba? Sabi ko, yung non-DHPs like verapamil, this is for the treatment of CSAP since it lowers oxygen demand. And for the long-acting naman, there are alternative treatments. Then for short-acting DHPs, generally ang short-acting DHPs, they are avoided in treating CSAP. Okay? Generally avoided sa CSAP. Kasi kapag gumamit ng short-acting DHBs, di ba vasoselective sila? Ano yung affected? Heart or arteries? Arteries. Okay? So, arteries, dinadilate nila yung arteries. So, posible na at high concentration, okay, pwedeng mag-cause ng reflex tachycardia. Yung DHP, CCBs, mataas yung risk sa reflex tachycardia. That's why kung gagamitan siya for Prince metal angina, okay, kailangan merong taga-mask ng reflex tachycardia. And that is beta blockers. Okay. Now, before I end the lecture, balikan natin yung outline. Okay, last na niya siya. Ayan. For angina, anti-anginals. So, na-discuss na natin. Check nato kung na-discuss ba nato tanan. So, I have discussed already the nitrates. Okay? Na-discuss ko na rin yung CCBs, yung dipyridamole, na-discuss na natin kanina. Isa siyang phosphodiesterase inhibitor, ultimately causing vasodilation. And finally, beta blockers. Meron din tayong non-vasodilator na CCBs ha. Yung cardiac acting example si verapamil. Cardiac acting.